That sounds excellent. We're happy to be working with you in this project for sure. Very glad to be here.
Right. So thank you so much again, dear colleagues. So, dear webinar guests, dear colleagues, physicians, doctors, clinicians, social workers, lecturers, professors, dear tomorrow's doctors. I see that some of my students are also attending this session right now, and constantly I'm trying to update the list right now as well. So I would like to welcome all of you to our webinar. Today's our gathering is about the resources for improving healthcare in people with intellectual and development disabilities. This is the informative webinar where you'll learn about specific tools that can help improve clinical competency and facilitate better health outcomes for people with IDDs. So you'll learn about the healthcare passport, the health screening tool, the universal pain assessment tool, and other resources as well. You'll also be invited to participate in a web-based training program specifically geared toward healthcare providers, social workers, and health professional students. Well, I gotta say that there is the limited amount of participants will have the opportunity to take an online IDD healthcare training course and receive continuing education credits without costs. So this is something that Dr. SQ-Day will be mentioning in his part of the speech. I'm going to introduce our dear guest, Dr. Craig SQ-Day, to you right now. So Dr. SQ-Day is a board-certified fellow of the American Academy of Family Physicians and the American Academy of Developmental Medicine, and is the president of Intellect Ability. He has more than 20 years of clinical experience providing medical care for people with IDD and complex medical and mental health conditions. Well, he's the founder of DETECT, the Development Evaluation, Training, and Educational Consultative Team. This team provides clinical training and support to health professionals in the state of Mississippi in the United States. He's also the author of Clinical Pearls in IDD Healthcare and developer of the curriculum in IDD Healthcare, an e-learning course used to train clinicians on the fundamentals of healthcare for people with IDDs. So IDD, this is the intellectual and development disabilities. So now I would like to transfer the stage to Dr. SQ-Day. Dr. SQ-Day, the stage is yours.
Thank you very much for having me today. It's really an honor and a pleasure. And it was the first thing I'll do is ask for forgiveness in any mispronunciations, including for you, Dr. Dugashvili. I have to get the pronunciations right. So forgive me if I get those wrong. But it's a wonderful opportunity to be here and share something that I'm very passionate about. And that's anything that we can do to improve healthcare, health and wellness, improve lives of people with intellectual and developmental disabilities. I spent my career, in the beginning of my career in this field, learning a tremendous amount because I was very ill prepared as a healthcare provider. I was not aware of the different nuances of providing healthcare for people with intellectual and developmental disabilities simply because I really wasn't trained in my health professional program. I learned a tremendous amount from nurses, from direct support professionals, from people with disabilities themselves over the years, and have kind of made it my mission to do what I can to provide resources and tools and education and training to healthcare providers so that they can learn things a little bit faster than I did and improve, clinical skills in providing healthcare for people with IDD. So I'm going to talk about some of those things today that we have. And if you should have any questions at any time, you can type them into the chat box, and Dr. Dugashvili will feed them to me, or we can have open conversation as well towards the end of my presentation. So I'm hoping that you can see my slides. And I think you can. And so we already talked about who I am, so we'll skip over this one. I'll tell you a little bit about the company that I'm with. Our company, Intellect Ability, is based in Florida in the United States. And underneath our company, we have 3 divisions. The health risk screening tool is our primary tool. And I'll talk about that in a little bit more detail as one of the resources that's available. Our academy division is our e-learning division, where we have courses that teach all levels of supporters about health issues and people with intellectual and developmental disabilities, from direct support professionals to nurses, and to physicians as well, and medical students. We produce all of our courses in-house. We have our own production division. And then we also have a person-centered services division, which is where we provide education and training to organizations to help them move towards more person-centered supports. And that's where we are, instead of just deciding what we think is best for the person with the disability, that's where we make sure that we learn to include what that person wants for their lives and what things are important to them, and create a shared plan together. So that's what person-centered services is all about. So let's talk first about the health passport, which is one of the things that got Dr. Dugashvili and I together at a presentation at AADMD. I mentioned the health passport, and we've been working together to provide a version of this health passport in Georgian. Thanks to Dr. Dugashvili in translating that. So let me tell you a little bit about what that is. A health passport is a document. It is a document that has some of the basic information that we're all used to that's important, such as demographic information, where a person lives, who their doctors are, their race, their age, all of these different things. It has some important clinical information as well. So it has information about their past medical history, their previous, their medications, their diagnoses, their previous surgeries. But it goes a little bit further. And we know that people with intellectual and developmental disabilities often have difficulty communicating verbally, and they aren't able to necessarily tell someone when they're hurting, where they're hurting, what they like, what they don't like. And so it has this document has a place to put all of this information as well, where you can include information about what the person likes, what they don't like, how do they respond to pain, how do they show that they're hurting. So it's a lot of social type information as well about interaction and how supporters can interact with that person better as they move forward in providing care and support for that person. So it helps a supporter, and when I say a supporter, I mean anyone who works with that person. Someone who might live with them or work with them on a day-to-day basis, helping them with activities of daily living like getting dressed or eating, all the way up to healthcare providers. It helps people who don't know that person very well have a concise document where they can very quickly gain information that can help them communicate with that person better and help them understand what that person might be communicating to them in the form of various behaviors. So here's an example in English that I'll kind of take you through. And then we'll show you the Georgian version and let you know where you can download that document and use it. So the first part of this document has demographic information, as I mentioned. So this is all fictitious information. This is Thomas Jefferson, one of our presidents early on. So you have name, address, race, marital status, all of these things. We ask that the person's physicians be listed, their dentists be listed, and so that you can have that contact information readily available. On the second page, there's some important clinical information, such as their various diagnoses, their medications, their allergies, different types of allergies, and then how does that person experience or pain, or how do they show that they are in pain? That is such an important bit of information that we should all be aware of, because people express pain differently, especially when they can't tell you verbally where they're hurting. It talks about their manner of mobility. People some people walk, some people use a wheelchair, some people might use a walker or a cane or some sort of assistive device. And those things are so important to know, because we need to know the person's baseline. Because if we don't know the baseline, we won't be able to identify changes as well. So that's another important use of this document. So it talks about the person's diet and the type of assistance that they might need in eating or drinking as well. It talks about weight, and if you work in this field, and we know that weight is a big indicator of health issues. Either weight gain or weight loss can be a very big indicator of various health issues, but it's particularly important in this field, where sometimes people have a hard time getting enough nutrition, and it's very, very important not just to know the patient's current weight, because their baseline weight may be underweight for most people without a disability, but also to know the change in rate. Has their weight gone up or down over the previous several months? So it talks about the best way that a person can take medication, because not everyone can swallow a pill. How do they go to the bathroom? Do they need a specific assistance? And then we get into the communication part of this, where we talk about different ways that they might communicate best. Do they use gestures? Do they use sign language? Is it through behaviors? What about hearing? Is it normal, or are they hearing impaired or vision impaired? And then other social information, like how do their friends see them? It's very important that we present people with disabilities as people first when we're looking at them to provide health care. We should talk about their likes, their dislikes, the things that they enjoy, how they interact with other people, so that health care providers can really make sure that they see them as a person and not just a disease or a specific disability state. So it talks about, what do they like to do? How do they, express positive things? How do they express negative things? What are the things that they dislike? Are there certain sounds that might be startling to them? And all of these things, you can imagine, if you know all of this information about a person, it can help you so much in interacting with them, building a better clinician-patient relationship, and overall providing better health care. So again, ways that they, again, we talked about communication, different ways they might interact with smiling or hugging or whatever it is they like to do. How do they interact with strangers versus how do they interact with someone that they know? What are things that help them pass the time? So on and so forth. In this version, we also have a space for the health risk screening tool scores, because the health risk screening tool, which you'll learn about in a minute, is very important. And then some room for additional information. So thanks to Dr. Dugashvili, we translated this into Georgian, and this is now available to you. This is in a fillable PDF format, so you can download this document, type in all of your answers, and save the document for each person. And this is something that you may want to use as a clinician, but you should also consider recommending it to anyone that works in this field, any family member who has a person with a disability, because they can fill this document out. This is something that you should fill out ahead of time, that they should have readily available. And let's say the person has to go to the hospital. You grab that document and you take it with them to the hospital, and you can give that to anyone who will be working with them so they can get to know them quickly. Let's say the family member or their supporter is out of town for a few days and they have someone else coming in to provide support. They can have this document that can give them all of this concise information. So you can download this here on our website at replacingrisk.com on the articles page. It's under resources and articles, and I'm sure Dr. Dugashvili can email it to you if you contact him directly. And I'll post this link in the chat after I finish my talk, so you'll have that as well. So that's a little bit about the health passport. Are there any questions at this point about that before I move on?
So, dear guests, if you're having any questions towards Dr. Escude, you're most welcomed. And Dr. Escude, I'm pretty sure that we can actually upload and attach this link, downloadable link, I guess, to the resources of our video afterwards as well. So we are going to manage this stuff as well.
Sounds good. So you'll have multiple places that you can download it. So let me tell you about another resource that's available. This is the Health Risk Screening Tool. And the Health Risk Screening Tool is a web-based instrument, so it can be accessed anywhere you have a web connection. And it's a screening tool to screen for health risks in people with intellectual and developmental disabilities and other types of vulnerabilities. It's also applicable for people with physical disabilities, disabilities associated with aging, people who have had a traumatic brain injury, people with dementia, but it's primarily used in people with IDD. And the tool quantifies health risks based on objective criteria. And I'll show you a little bit about that in just a second. It helps not only in identifying this risk, but it helps to mitigate it by providing action steps that people who support a person with a disability can take that can help reduce those health risks in a person. It can also be used to help determine if a person needs a different level of service or an exceptional level or a higher level of service. For instance, in a couple of states here in the United States, they use the tool to determine if a person might need additional levels of nursing services or additional levels of case management services, because the tool can objectively identify which people are at greatest risk for poor health outcomes. And it enables ongoing monitoring of the person throughout their lifetime. And it's also used in transitioning people from one level of service to another. So if a person is in, say, a group home and they're moving to some other type of residential setting, or they're not receiving services, this can help prioritize them in terms of how quickly maybe they need services based on health risks. So this tool was developed quite a while ago, back in 1992, by the founder of our company, Karen Green McGowan, who is a nurse who worked in this field for many years. And she developed this tool on a paper form because of a lawsuit, actually, in the state of Oklahoma, where people were moving out into community settings and not going to have the same level of medical supervision that they were having in a larger facility. And the judge wanted some mechanism in place to identify which people were most likely to have health issues and poor health outcomes. So she worked to develop this tool. It was extensively field tested back then on 6,000 people. Now it's used in 26 of the 50 states in the United States. And the web-based version was released in 2006. So these are the states where it's used. We actually have a couple of clients in Canada now as well. We have 8 states that mandate it through the State Department of Developmental Disabilities, that it's used across their entire population of people with intellectual and developmental disabilities that are served on what we call a waiver system here in the United States. And then the other states use it to varying degrees. We have well over 2,000 different provider agencies who use this tool. So how does it work? And I'm giving you the very short overview version. There are 22 different areas where a person is asked specific questions that are basically yes or no questions. There's really no gray area. And the tool has logic built into it where after you answer all of these questions, it then provides action steps that people who are working with that person can take to help reduce health risks. So these are the areas that the tool addresses. So they're in 5 categories: functional status, behaviors, physiological, safety, and frequency of services. And you can see that it covers a lot of things that are very important in very high-risk areas in people with IDD. And if you work in this field, you'll know that these areas are indeed very high-risk areas. If you don't work in this field, you will come to know that. But things like eating, ambulation, transferring, bathroom issues, behaviors. We know that behaviors are so important to understand in people with IDD, because so often a person may have some aggressive behavior or self-abusive behavior where they're hurting themselves, but it may be because they're having some undiagnosed underlying medical or dental condition. And that's what Dr. Dugashvili is going to talk about in terms of assessing pain. And I'll touch a little bit about that as well, too. So it's so important to look at different behaviors to see if maybe there could be some underlying treatable, fixable condition that can improve the person's quality of life, reduce unnecessary suffering, and maybe even save their life. There's a physiological section where we talk about gastrointestinal problems and seizures and anti-epileptic medications which have risks associated with them, bowel function. That is so important in working with people with disabilities, is to understand how prevalent constipation and bowel impactions are, and how many very difficult, challenging, and serious problems that it can cause if it's not addressed. It looks at nutrition issues, other types of high-risk treatments, injuries, falls, and then also frequency of healthcare visits, because all of these things affect a person's quality of life and can be an indicator of poor health. So a person is asked questions, they receive a score in each of these areas, and then you get an overall healthcare level from 1 through 6, 1 and 2 being low risk, 3 and 4 being moderate risk, 5 and 6 being high risk. And these healthcare levels have been studied and proven to be a very good predictor of death in people with intellectual and developmental disabilities. The higher your healthcare level, the higher your risk of death is. So while it's nice to know where those risks are, what's really nice to know is what can we do to reduce those risks? What can we do to mitigate those risks? So people who support people with disabilities collect lots and lots of information. This is all information that they already have, that they're documenting on different types of reports and different types of, documents and just lots and lots of information. What the health risk screening tool does is it helps to take this information and put it in categories, align it, and to identify which areas are of highest risk, and then give you action steps in the form of service considerations and training considerations to help mitigate those risks. So a service consideration points someone to a specific service. So what I mean by that is, let's say when the questions are answered, person says yes, they have a pica behavior. So pica behavior is eating things of non-nutritional value. They may be picking up things off the floor. They may be chewing on clothing items. So let's say you answer yes to that, and you answer yes to the person wakes up at night agitated, and you answer yes to the person is agitated or aggressive around meal times. Well, the tool knows that all of these things can be signs of undiagnosed gastroesophageal reflux disease. And the tool would then provide a service consideration that says, have this person evaluated for gastroesophageal reflux disease. And that is actually a very common condition, very common in people with intellectual and developmental disabilities, and all of us. But the difference is, in people who can communicate verbally, we can describe what's going on and the clinician can understand that. But in people with disabilities, they may present with different behaviors that are indicating this. And if we're not aware that these different behaviors can indicate that this underlying medical condition, it may get missed and the person may continue to suffer for years. Training considerations are also provided by the tool. And so those training considerations point people to the types of training that anyone who works with that person, that helps to support them in their daily life, should be aware of. For instance, let's say this person has had a bowel obstruction in the past, and we know that a person who has had a bowel obstruction is at higher risk for having another bowel obstruction. So anyone who works with that person needs to be trained on what are bowel obstructions, what does it look like, what does it look like in this particular person? Will they see, what signs will they see in this person? Maybe this person will express this by balling up in a chair, holding their knees to their chest, and moaning and groaning and becoming agitated. So we need to make sure that people understand what to look for and what to do if they see early signs. So the health risk screening tool provides this document that puts the person in the center and helps everyone around them who works with them to have a common way to talk about health issues in that person and how they can each play their own role in reducing those health issues and health risks to help better support that person. This is data showing the healthcare levels. You see HCL 1, 2, 3, 4, 5, 6 on the bottom. And you see this graph here. This is data, it's interestingly enough, from the state of Georgia in the United States, who does annual mortality reports each year, and they use the health care level from the health risk screening tool and tie it to the overall mortality rate. And so this graph shows that with each 1 point increase in the healthcare level, that there is a significant increase in the risk of death. And it's about, in this last year, it's about a 59% increase in death with each 1 point in the risk of death, with each 1 point increase in the overall healthcare level. So this information has been published in the Journal of Nursing Measurement as well. So there's data to back up this. So that's the health risk screening tool, and I'll stop there and see if we have a question or two about that, or anything else that I've talked about before I move on.
Hello, I have a question.
Yes.
Regarding that. Like, are these services and tools affordable, for example, for people who have economical issues, like how they can afford these services?
So these tools are provided to agencies and to states who then use the tool and in support of their person with a disability. That specific tool is not available specifically for one person or one family member with a disability to use. However, it is very affordable. It costs approximately $3 American dollars per month for someone to have access to the tool, to be screened on the tool. So it's $36 a year for unlimited use. This includes all training of people who would be doing the screening, unlimited access. You can screen as many times as you'd like, and all customer support as well to make sure that that you are using the tool appropriately, that you know how to use it and how to get the best benefit from it.
Thanks for your answer.
Sure.
Everything is clear now.
Sure. So the next thing I'll talk about is another resource that's available to you, and this is the Clinical Pearls in IDD Healthcare. So I don't know if you use this term where you are, but we use it a lot in the United States. A clinical pearl is basically a little tidbit, a little small piece of information that is clinically relevant, that's usually based on experience or observation. And so what is a clinical pearl in IDD healthcare? It is a small bit of information that is based on experience that's related to health and wellness in people with intellectual and developmental disabilities. So one thing I found in my career is that there was very little information about providing healthcare for people with disabilities. There were a few resources here or there, but for most people to quickly gain information in clinical information that can be helpful, I had a hard time finding this no matter where I looked. It was actually very nice when I learned about the American Academy of Developmental Medicine and Dentistry a number of years ago, because I finally found a group of other people with similar experiences, and also people that I could learn a tremendous amount from. But I decided to create this guide to help convey information, again, to all levels of supporters. This book provides clinical information on a wide variety of topics that can help anyone who touches the lives or works with people with intellectual and developmental disabilities. The information is helpful to physicians, to dentists, to nurses, physical therapists, speech language pathologists, psychologists, support teams, direct support professionals, families as well. It's used to provide in-service training to staff who work with people on specific topics. It's also used to help physicians understand some of the things that we were not taught maybe in medical school. For instance, if a person is being taken to a doctor to rule out underlying medical causes for this new behavior that this person has, many times the physician is not necessarily aware of what to look for. What are particular underlying conditions that this behavior might point to? Well, there's a clinical pearl, for instance, in this book that talks about specific behaviors and which specific underlying medical conditions that behavior might indicate to help that clinician know what to do and what to look for. And it can help anyone gain some insight into that. So the way this book is put together, it's purposely put together in a binder, and here it is right here, and it's a binder, and each page is on heavy cardstock, and you can take each page out, and we give permission for people to copy pages so that they can give it to people. They can give it to a family member, they can give it to a doctor, they can give it to a direct support professional, they can use it in training to give them information that can be helpful and that can be used. It's also available in an ebook as well. Again, I already talked about some of the uses, but sometimes nurses will take this information, or direct support providers will take it to a physician to help give them some clinical information for in-service training for family members. It's also licensed to be used in nursing manuals for states, and it can also help for people who are preparing for any type of certification exam in this field. This is the table of contents. There are 55 clinical pearls. They cover general support areas, including starting with what does support look like? What is a residential agency? How does a support team work? Talks about person-centered thinking and person-centered language, issues with falling, end-of-life issues, quality of life and what it means. Then there's a medical support section that talks about an approach to evaluating people with disabilities. It talks about the Fatal Five, which I'll touch on in just a second. It talks about medications and different issues and metabolic syndrome and polypharmacy concerns, which we know in this field is very prevalent, where people with IDD are placed on many, many different medications, sometimes many psychotropic medications, and this can often cause more problems than benefit. Then there's a behavioral section. Clinical Pearl number 40 is the one I mentioned that talks about medical causes of adverse behavior in people with IDD. There's a dental causes of adverse behavior as well. There's an oral health care pearl as well. And then there's a section on nutritional support. So what I want to do is just touch on a few of these to show you in a little bit more detail as to what this actually covers. And one of the ones that I think is very important is the one that touches on quality of life in people with intellectual and developmental disabilities. And I'm going to tell you about Mary. Mary was an older person with a severe level of disability that was living in a residential program, and she had an episode of aspiration. She developed pneumonia and was sent to the hospital. And a few days later, we received information that she had been placed on hospice. So hospice care is end-of-life care, where a person is thought that they're going to die soon. So it's basically comfort care. And I contacted the physician to find out why Mary was placed on hospice. Had her pneumonia gotten, just overwhelming, and was she not recovering? And she said, oh no, she has recovered from her pneumonia. She's not requiring oxygen, but she just won't eat. And so, she's old. She really doesn't have a good quality of life. So we placed her on hospice. So the assumption was made that Mary had a very poor quality of life, and well, she wasn't eating, she was old, let's just help her ease on out of life. And I promptly said, you know what, I tell you what, since she's better from her clinical issues and not requiring oxygen, let's discharge her back to our program here, and we'll take things from here. And so we evaluated Mary when she came back, and of course she was very constipated, which will make people not eat, and they did not recognize that at the hospital. And so we relieved that. And when she was back, she was around people who knew her, who knew how to work with Mary, who knew how she liked to eat and what she liked to eat. And Mary began eating fine, and she went on to live a number of years longer. So this is a good example of where, when we don't always appreciate the quality of life of a person, or we think that a person's quality of life is lower just because it's different, then we may treat them differently. We may try to provide a different level of health care. So in this clinical pearl, it talks about quality of life, and there are a few definitions, but the one I like the best is the one on the bottom right. The quality of life is the extent of positive perceptions of current life circumstances. It's the perceptions that that person has. And Mary was a happy person and laughed and interacted and smiled and enjoyed life, even though she had a severe level of disability. And so this pearl tries to emphasize to clinicians and to others that a different quality of life is not equal to a lower quality of life. So let's go on to another one. And here's a question for you to illustrate a common misconception. People with IDD aren't sexually active and don't need reproductive counseling. And a lot of people think that they don't have sex.
Of course it's false.
You're right. And that is definitely false. Definitely false. So number 9 talks about sexuality in people with IDD, and it goes into how that sexual drive is a natural occurrence, and more than likely people are going to act on it. There are also higher rates of sexual abuse and other abuse in people with intellectual and developmental disabilities. So it's even more important to educate a person at their level and educate the people who work with them and support them about sexual issues, about privacy issues, and that how you should consider contraception the same as you would with anyone else, and include their support team and support staff in that decision-making process. So again, to help people think about this, that it's important to address, not something you just shove under the rug. We know that people with disabilities are aging, they're getting older, and in part that is because there is better health care and things are moving in a good direction. But as people with disabilities age, we must also think about things that we see in all of us who age. So it's important to remember that there should be screening. We should screen people for health risks and health issues as people get older that we might not have thought of before. You know, years ago, the life expectancy was much lower, and so you didn't see things like arthritis and dementia, and maybe, well, you did see poor dental care, didn't you? Way earlier than we should have. But we didn't always think about those things. So this clinical pearl talks about making sure that you encourage good eating habits and healthy eating and being aware of long-term medication side effects, because this person may indeed live for many years. So it helps to make sure that we're thinking long-term about the care and support that we provide for people with IDD. Now, clinical pearl number 19 is the one that this is the introduction to the Fatal 5+. So this is a very important topic in this field, and some of you may be familiar with it. The Fatal 5 are the top preventable causes of morbidity and mortality in people with intellectual and developmental disabilities. When I first heard about this, we were calling it the Fatal 4, and then when I joined our company, we call it the Fatal 5 because we added one, and now we call it the Fatal 5+ because we've got 6, and there are a couple more that we have to consider as well too. But the big ones are aspiration. We know that people with IDD are at greater risk for aspiration, getting food or fluid into their lungs and having a serious infection, and it's a higher cause of death in people with IDD. Constipation and bowel obstruction is unbelievably common in this population, and so often not thought of and not missed, and a very common cause of behavioral issues and medical issues. People with IDD have higher incidences of seizures, especially the people with more severe and profound levels. You're more likely to have very complex and very challenging seizure conditions. Dehydration we see often associated with some of these other conditions. Sepsis also is a big issue. We call it the silent killer. And sepsis can be hard to recognize in people without disabilities, but in people who can't communicate, and it's hard to identify the early signs, people who don't communicate verbally, it can be easily missed, and it can rapidly progress to death. And then gastroesophageal reflux disease is another big issue. While it can lead to death through gastrointestinal bleeding or increasing the risk of esophageal cancer, more often we see a lot of suffering, unnecessary suffering, people who are having chronic reflux that end up having chronic, self-abusive behaviors and aggressive behaviors because of this undiagnosed gastroesophageal reflux. So that particular clinical pearl touches on each of these, and then the following 6 go into each of these in detail. So that's just a little bit about the Clinical Pearls book. And again, I'll stop before I move on to my last segment here about the curriculum in IDD healthcare. Are there any questions?
Well, even if there are no questions, but so far, we're going to have the opportunity to have approximately 10 to 15 minutes for the questions and answers.
Great.
Yeah.
Then I will move on.
If,
all right.
If I may, good evening. Good evening.
Hello.
If I may, yes, I am pediatrician, professor of Gruni from Gruni. Thank you so much for this opportunity. And I'd like to ask about the children. We know, do we have some part about children, we have some intellectual disabilities in children. Yes, it is a neurological, neuromuscular disabilities also. Like, I see you have one part about Down syndrome, yes, in your book.
Yes.
So do you have any, yes.
Yes. So the book is geared to talk about common conditions in anyone with an intellectual disability rather than specific diagnoses. I did include one clinical pearl about Down syndrome because it is the most common genetic condition.
Yes.
So I did include that one specifically, but I don't really go into specific conditions, specific diagnoses. It's more about these are things that are common to anyone, and they affect young people as well as older people and people of all ages. So that's kind of how the book is written.
Okay.
So it's applicable. Sure, it's applicable information, and thanks for what you do there. Incidentally, it's interesting. At least in this country, we find that pediatricians are more attuned to working with people with intellectual and developmental disabilities because they see them younger. The challenge is when people get older and they're moving to some adult level of healthcare, and that's where we find to a much greater extent that people have trouble accessing healthcare, from clinicians who understand their needs. But thank you for what you do there.
Thank you.
So the last section of my talk is about the curriculum in IDD healthcare, and this is where you're going to get an opportunity to participate in this project that we're doing here. So as I mentioned to you, I knew almost nothing about this field when I started in this field, as many clinicians do. And I decided a number of years ago that I was going to figure out a way to try to easily give this information to healthcare providers, give them an opportunity to learn this information. Because as we're trying to improve healthcare for people with IDD, we must look at it from a medical student standpoint. So we must do better to teach medical students about this. But we also must look at healthcare providers who are already practicing, who are already, seeing patients, and help them to have an easy way to learn about this information. So this course is designed to do both. The course is geared primarily to physicians, nurses. There's a little bit of oral health care in the course, but it's not so much about specific oral health care. So for the dentists in the class, it's not going to teach you a lot of dental issues, but it's going to teach you a lot about behaviors and pain and medications and just overall health care in people with IDD. Nurse practitioners, physicians, assistants, really any clinical personnel. It would be applicable for physical therapy and occupational therapy as well, because it provides an overall orientation to this field and providing healthcare. So, and again, the purpose is to very concisely teach fundamental principles of providing healthcare that every person who works with a person with a disability should know. It doesn't teach you, for instance, how to treat aspiration pneumonia. It's not going to say these are the antibiotic choices. This is the disease process. This is, this is what their hospital course look like. What it does teach you is how does aspiration pneumonia look in people with IDD? How does it present differently? How do you assess it? What's the best way to assess it in a person with a disability? So it orients healthcare providers into the approach of all of these different issues in people with disabilities and how it's different than in people without intellectual and developmental disabilities.
Dr. Escude, is it pretty much about the signs and symptoms, I guess, to be detecting those signs and symptoms at an earlier stage so that no chronic condition is going to develop and it's not going to be hard to treat the patient afterwards? So the early assessment, I would say, is the most important focus, I guess.
I would say, I would agree with that. It's a lot about early assessment, a lot about when you have a person with a disability who presents to your office or to your emergency department or whatever, that you have an approach in your head on what to look for, what to do, what are the more common things to rule out, and how to communicate with that person, how to communicate with that person's provider, what medications to avoid, or to look for, what lab tests you may want to do over some other lab tests. So that's the type of information that it provides. It is an online interactive e-learning course. There are 6 modules in the course, and I'll touch on those to give you a little idea about what each of those cover. It includes interactive knowledge check questions, so you'll be asked questions throughout the course, and then at the end of each module, there is a post-test where you're tested on the material. And in the United States, we have requirements for continuing medical education. I'm sure you have some equivalent there. It may be called something a little different. For physicians, it's called CMEs, continuing medical education. For nurses, it's called CEUs, continuing education units. This course is approved in the United States for both physician CMEs and for nursing CEUs. So hopefully, if you decide to participate in this, that these credits will be applicable to you as well. These are the 6 modules that are in the course, and I will say that of course, some of this is geared towards or is going to be specific to the way things are in the United States. But the more I learn, the more I understand that all over the world we face the same challenges. But the first module talks about IDD healthcare, where we were, say, 100 years ago. It moves to where we are now and how we got to where we are now, and talks about the status of IDD healthcare now. And then it talks about where do we want to go? Where do we need to move towards? So this is basically an orientation to healthcare for people with IDD, how it evolved to where it is now and where we need to go. The second module is a very clinical module. It's healthcare basics in IDD. And that is where we talk about the fatal 5 conditions that I mentioned. We go into detail about aspiration and constipation and dehydration and seizures. And we talk about osteoporosis. We talk about general lab considerations to be aware of. We talk about a little bit about medications and interactions, and just a lot of different clinical issues that we see more commonly to help orient clinicians to how these things might look in people with IDD. The third module is common behavioral presentations of medical conditions. And frankly, this is my favorite thing to talk about. I'm going to Connecticut tomorrow to do a talk about this. But it's where I cover in a case study format, which is one of my favorite ways to learn, is hearing real life cases and how the diagnosis was made. So I cover a number of different cases of where people presented with behavioral issues, and it turned out to be an underlying medical cause. And then I relate the different behaviors and how they might point to specific medical conditions. The fourth module is dual diagnosis. Now, that's the term that we use here for people that are diagnosed with both intellectual and developmental disability and a mental health condition. And as you are aware, it can be very challenging to diagnose mental health conditions accurately in people who don't communicate with words. How do you know what someone is thinking, what's in their head, what their thought processes are when they have difficulty communicating verbally? But there are things that you can learn. There are techniques that can help you tease out, is this issue a medical issue, a psychiatric issue, an environmental issue, a social issue? So this particular module talks about that. It also talks about the polypharmacy issue, the polypharmacy concerns and overprescribing of psychotropic medications. It talks about different classes of medications and how they might affect people with disabilities differently, good prescribing habits, things like that. The fifth one is on effective communication. So this is where we talk about the different ways a person with disabilities may communicate to you and how you can communicate to them, what things to think about if you're not sure what's going on, what questions to ask, what's a good place to start. And I'll tell you, as a physician, when I was asked to see someone with a significant disability who was having some sort of medical issue, how it got presented to me most of the time was, you know, this person's just not acting right. I don't know what's going on, but he's not acting right. And that was about all the information I got. And that's a very challenging place to start if that's all the information you have. So I had to learn, okay, what questions do I need to ask? And one of the big ones is, when was their last bowel movement? How often do they have bowel movements? Are they eating well? Are they drinking well? How are they different from their baseline? So in this particular module, it teaches these particular components as well too. And then the sixth module, it's again, nothing but case studies that illustrate components from all of the other modules and tie all of these together. So that's a little bit about the course itself. These are just screenshots of some of the parts of the course, so you can kind of just see what it looks like. This is all narrated. You have the ability, it's all in English, of course. You do have the ability to play it at a faster speed, because I know many of us like to learn a little bit faster than we can talk sometimes. So you can do that as well. Here's an example of one of the case studies about you know, Sheila with a disability who was fidgety and couldn't sit still. She was putting her hands in her pants. She became upset when taken to the bathroom, and she'd bite her arm. So what do you think might be going on in that instance? And in her case, while that can be a number of different things, she had a very bad urinary tract infection. So it goes into that. So currently in the United States, the course is being used by the state of Georgia here to train physicians in the state. The Developmental Disabilities Association for that state has licensed it to use through and is providing it to all physicians in the state. The state of New York, through a provider agency who received a grant, is also using it to train physicians in the state of New York. There are some what's called a regional IDD authorities in the state of Texas are using it to provide physician training, because these organizations provide mental health care in their catchment area, and they received so many referrals for mental health issues that turned out to be underlying medical issues. And they found out about the training, and they wanted to provide this training to healthcare providers so that they had a better understanding of the actual medical issues. We also have had our first medical school license the course. We have a couple of others looking at it now. William Carey University College of Osteopathic Medicine is now using this course in all of their incoming first-year medical students. They did an extensive pilot of the program the previous year, and the results were very favorable. They published, they were able to present the results at a national conference on colleges of osteopathic medicine, and they're further expanding the study to include all of their first-year class, but they've licensed it and plan to include it. We also have a provider agency here in the United States who provides IDD-specific telemedicine services, who uses it to train all of their physicians as well. This is just some feedback. I'm not going to read all of these, but let's just say that from practicing healthcare providers who have been in the field for many years, all the way to medical students, to nurse practitioners, anyone who's taken this course has had very, very positive things to say about the course. And it's doing what I really wanted it to do, which is to provide very usable, practical information in a very efficient manner to healthcare providers to orient them to providing healthcare for people with IDD. So what we're going to do in the country of Georgia pilot project is we're going to open this up to the first 30 people. And I'll tell you, if you're on this course, I don't know how many people, it looks like we have 63. And you really want to do this and you can get in time, you jump in and send your email to info at the info address there that you see on the screen. We'll get you in, even if we get over 30 people. So, okay, so I see the how long will it take? So the course itself has a 4.5-hour run time, and that's if you play it at normal speed. And then there's also a little bit of additional time at the end of each module to answer the questions. Once you answer all of the questions and you pass the post-test, which is very easy to do if you watch the course, you will then be automatically asked to see what type of continuing education credit you want. You fill in the information, you fill out a survey, and you will receive your certificate right away. So it'll take you about probably 5 to 6 hours. If you play it faster, you can do it shorter. So that's about how long it takes. You can access it any time of the day or night. And what you would need to do is just provide your name and your an email address to this send it to that group there, or to Dr. Dugashvili as well, or to me, which I'll give you my email address in a minute. And we ask that you register by November 8th, and we will then send you an email with login information, and you can log in and take the course at your leisure.
And it is pretty much first come, first served, right? We have the limited slots over there, so hurry up, whoever is interested about it. So
that's right.
It's a great opportunity that Dr. Escude has provided over here, and for some amount of people. And yeah, so take that opportunity.
Yep. And with that, I'm going to conclude my portion of the talk here. My email address is there at the bottom. It's craig@replacingrisk.com. And I would love for you to contact me about anything that you want to talk about related to this field. I always love hearing stories about what people are doing, challenges they're facing, and successes as well. If you have any great success stories, I love hearing those. And you can also learn more about some of the things we talked about and find the book and other things at replacingrisk.com, which is our company's website. So with that, I thank you very much. I will be here for questions and answers, but I'm going to turn it back over to Dr. Dugashvili.
Dr. Escude, thank you so much for your presentation, for your speech, interesting speech, and the interesting tools that you are actually trying to provide. And those are really absolutely so supportive. And I'm hoping that many of the physicians, doctors, tomorrow's doctors, students will be interested about the particular matter. Right now, we're pretty much open for question and answers. If there are any questions, Dr. Escude is going to be welcoming your questions. All right, as far as I'm seeing, like silence means that Dr. Wong, yes, I mean,
yes, I made it as clear as it can be, right?
Right. So well, the silence means that everything was pretty much understandable, and it is very much appreciated. But first of all, Dr. Wong, before you will be given the stage of ours, I want to introduce you to the society or to the audience over here, to the physicians, to the students, to the social workers. I'm pleased to announce that Dr. Wong is with us today. Dr. Wong is the president of AADMD, the American Academy of Developmental Medicine, and he's also one of the very true members and representative of the Special Olympic Special Smiles Division. And I would want you to give our audience a little bit of vision towards the aspects. Dr. Wong, please.
It's my pleasure. Thank you, Dr. Dugashvili, and for arranging for this wonderful presentation. And Dr. Escude, always a pleasure watching you. I can't say enough about how proud we are of you as an AADMD member, but more as a pioneer in education and medicine and dentistry. As Georgie mentioned, I'm the president of the American Academy of Developmental Medicine and Dentistry. And our focus is three parts. It's advocacy, education, and access to care. And we are thrilled that the youth, the young leaders, the young clinicians of tomorrow are being exposed in this way, because we're not treating teeth and gums, we're treating people. And as Dr. Escudé was saying, the more we learn about them, the better we're able to treat them as inclusively as possible, something like we would like to do, because many of this population is diagnostically overshadowed. We're underprepared in terms of education. There's such disparity in care and such negligence in our part, but we're doing better in education, in curriculum, in dental schools and medical schools in our states and internationally. We're trying to increase education, and Dr. Escudé is trying to increase education of our current clinicians as well. So it's not just about dentistry, it's not just about medicine, it's about a collaboration of health and improving overall health by taking care of people as they should. It's just a nice, just thing to do. And also remembering that self-determination is very important, that these individuals have a right to choose what they want to do. We have to be able to learn their language as well. Anyway, I just wanted to say thank you so much for being here, everyone, and thank you for being the pioneers and the soldiers, if you will, to tell others of the importance of learning this and sharing Dr. Escudé's knowledge, as well as aadmd.org. That's our website. And there are a lot of free resources there also. And we also have student chapters of AADMD where we talk between medical and dental and nursing and different healthcare provider students to join in learning more together. And we have what's called virtual grand rounds, which are free, and you can partake about learning about simple things. Like we just had one on autism and Down syndrome, and we have dental students and medical students present the case. We have residents, dental and medical students present the background. We have the residents present a case or two, and then we have a discussion. So it's a very interactive way of learning. It's not just about listening to old people like me talk about it. You get to hear about the youth of the community learning about together, and everything's free. So if you're interested in aadmd.org, look for it. We have student chapters, everyone. I'd love to have one in Georgia if we don't already have one, Georgie. But we're here to support you and your efforts. But thank you for your leadership, Dr. Dugashvili, and everyone who helps out with Special Olympics. I'm one of the global clinical advisors, and there's no joy to me than to get ready to start seeing our athletes at work again. So thank you for all you do, Dr. Escudé. Brilliant presentation.
Thank you, Dr. Wong, and I second so much the benefit of being a part of AADMD. It has just been wonderful for me, and so many resources that I didn't know existed before I found out about them. So I would highly recommend that you look into it.
Great. Thank you so much, Dr. Wong, for your speech portion. And basically, I would love to say that there would not be possible to organize this particular event without the vision and intention of Grigor Robakidze University, especially Professor Mamuka Tafkalidze, and also the Vice Rector Guliko Galdava. So we are appreciating that stuff, and this has been very informative, educational, I guess, and we have already raised some of the awareness in the audience, I'm guessing. So thank you again so much for being with us today and for sharing your thoughts. So, dear audience, I think if there are no questions left at this stage towards Dr. Escudé, I will transfer your attention, your precious attention, and I understand this is Monday, tough day. All of us have been busy, I guess, right? So me personally, I've been having like 8 hours of lecture and seminars, but still we're trying to stay energetic, right? So this is how we're doing this. This is how we're working in Special Olympics, Special Smiles, and this is how we're we're doing everything with the correlation with special needs patients, because they love it, they appreciate it, and this is what matters. So I'm going to try to share my screen right now and going to try to start sharing my presentation. So, well, I'm pretty sure that you can already see the screen of mine. Well, my name is Georgi Dulashvili. I'm DMD, I'm PhD, full professor of medical research methodology at Grigor Robakidze University, and associate professor of dental medicine at GAU at Georgian American University. I'm also the representative of Special Smiles, Special Olympics as a clinical director. Well, I had been trained for the particular vision and particular direction in 2013 in South Korea. That was the start of mine and integration of into this huge family, huge, very friendly and dedicated family, which is pretty much enthusiastic towards the direction that we are talking about right now. So this image was taken in Belgium while having the European Games of Special Olympics. And today I will be talking and touching some of the characteristical patterns of pain-related issues in people with intellectual disabilities. I will also touch the aspects of communication issues in vulnerable people regarding pain. And I will most importantly mention the use of the universal pain assessment tool for evaluating pain associated with TMD, the temporomandibular disorders dysfunctions in people with an intellectual disability. So as far as I am the physician, I have been there on the scene and I have been involved with the real patients. On the side, I'm also having my scientific work. I'm going to try to correlate and combine, make this synchronized characteristical pattern of the, let's say, practical work and the theoretical aspects as well. So, of all the forms of inequality, injustice in healthcare is most shocking and inhumane. Martin Luther King, and here we're going to start with people with disabilities and what they actually experience. Well, I'm going to give you a little bit of introduction and a little bit of a warm-up. So, greater unmet healthcare needs than people without disabilities. Unequal access to healthcare services. And Dr. Escude did mention the importance of having the access, the equal access to the healthcare services, and equity in that particular pattern is most important. They're having less education. They're having worse socioeconomic situation and outcomes, higher rates of poverty, and lower employment rates. Those are all of the components and ingredients that I've mentioned, which are pretty much problematic. So people with disabilities have a higher risk of developing secondary conditions, higher risk of comorbid conditions, so multiple, 2 or even more medical conditions can be running simultaneously without even being identified at an early stage or in general. Greater vulnerability to age-related conditions, increased rates of health risk behaviors, such as the patterns which were pretty much mentioned by Dr. Escude as well, obesity, smoking, physical inactivity, greater risk of being exposed to violence, high risk of unintentional injury, burns, falls, car crashes, high risk of premature death, and also the conditions such as schizophrenia and depression. All of those are really problematic issues, and they are nothing different from the non-ID patients. However, they are being pretty much lacking the concern from the medical society. Well, because of the certain reasons, because of the lack of understanding, because of the lack of knowledge toward that direction. So I have to mention a meaningful healthcare environment, what it is. So all of those components which I've listed are considered to be the, I would say, integrative parts of the healthcare environment, which is meaningful. So accessible, patient and family-centered, which can have other terms such as individualized or personalized type of care, compassionate, comprehensive, coordinated, communicative, collaborative, continuous, and culturally competent. I have to emphasize one of those listed over here, which is pretty much taking the first place, and all of the others are kind of connected with it. This is patient and family-centered care. I did mention that all of those other components are directly and indirectly as well connected with patient and family-centered approach. Now, pain-related issues in people with intellectual disabilities. Well, I'm going to try to emphasize the factor of those emojis and smileys that you are seeing on the screen right now, from the green up till the red, from the smiley that is actually happy and up till the smiley that is emoji that is crying. I will be touching this pattern whenever I will try to introduce to you the UPAT, the Universal Pain Assessment Tool. Beforehand, I will try to go for pain-related issues in people with intellectual disabilities. So, McCaffrey in 1968 did give a little bit of a definition of pain that was pretty simple. It's whatever the experiencing person says it is, existing whenever and wherever the person says it does. Yes, it is like this, and it's pretty simple, indeed. But we do have the problem. We do have the problem arising whenever we're dealing with people with intellectual and development disabilities. And this problem is such. What about the problem whenever it arises when a person cannot report what is happening to them? So it's impossible to understand whether the patient is actually having the painful condition. Well, you know, when I did understand this, I did understand this whenever I was having the real patient. Well, that was the Special Olympics Special Smiles division screening portion whenever we were trying to do it and fulfill this screening, let's say, pattern. It was in South Korea back in 2013. And I remember that I was having one of the patients who was actually having a bright smile on the face. Every single person would have thought that this person is having absolutely no pain, absolutely no medical condition, and everything is pretty fine with the person. However, I did identify that this person was in need of an urgent endodontic treatment. Okay, I'm going to be using some of the medical terms from the dentistry field, as far as I'm the representative of the dental, let's say, field. I will try to focus on the characteristical issues as well. So I did understand that, okay, sometimes it's tough for people with special needs, intellectual and development disabilities, to communicate their needs and their painful condition. And therefore, many of the doctors can misdiagnose the patient or miss the particular diagnosis at all. So here we have, on a scale of up to 10, how would you rate your pain? Both children and adults with intellectual disabilities have higher tolerance for pain experiences in comparison with healthy individuals, so non-ID patients. This may be associated and related to the factor and challenges in recognizing and communicating pain to others. So something that I've just told you. And the condition afterwards is maintaining to be chronic, and chronic condition is lowering the particular aspect of quality of life. So pain is difficult to identify when people cannot communicate. If pain is not identified, it cannot be managed and causes stress. Pain assessment is essential in order to identify pain. Pain assessment requires a combination of knowledge, health assessment, and observations. Now, something about the pain-related issues from the characteristical issue, whatever I have just mentioned. In people with intellectual disabilities, typical indicators such as crying, grimacing, elevated blood pressure, or tachycardia are actually missing. Why is it happening? Well, this can be these characteristical components of those signs and symptoms that you can catch. We know that patients are dropping the cues, and the doctors are supposed to be catching those cues, right? This is how we're working with the real patients. However, these cues are sometimes absent because of the damage to the CNS, the central nervous system. So, as a result, it is difficult to ascertain if the person is actually having the pain or not. Now we've touched the characteristical, very critical component that early assessment and appropriate intervention for pain enhances quality of life. Unfortunately, people with ID are less likely to see healthcare practitioners regularly or have their pain recognized and treated promptly. So you see, there are two very important factors. One is whenever the people with intellectual disabilities or development disabilities, they are having the lack of capacity of, let's say, visiting the healthcare practitioners. And on the other hand, they do visit healthcare practitioners, but healthcare practitioners having the lack of knowledge or possibility and capability to be identifying the particular pattern of problematic issue. Now, communication issues in vulnerable people regarding pain, some of the brief information. Pain in non-communicating people can be assessed by observing certain physiological changes such as towards the breathing, skin color, sweating, urination, blood pressure, and heart rate. There are some of the additional pain assessment characteristical indicators, which can be facial expressions, aggressive behavior, vocal expressions, and body posture. So communicating with people with disabilities is not easy at all, but we have to know some of the general guidelines and general characteristical components. I've listed them over here. So first of all, we have to speak directly rather than through a companion or sign language interpreter who may be present. So try to speak and talk and refer to the patient directly. Make the eye contact. Offer the shake of hands when introduced. Offering the left hand is pretty acceptable while greeting. Always identify yourself. Tell them who you are and what your role is. So if you offer assistance, wait until the offer is accepted. Do not jump straight ahead towards the conversation. Give the patient some space. Treat adults as adults, and this is very important. Do not lean against or hang on someone's wheelchair. Never distract a work animal from its job without the owner's permission. Listen attentively. We know that listening attentively is one of the basic components of communication skills. Sometimes people are thinking that listening attentively is just waiting for your turn. No, it's listening attentively, something more than that. I'm going to mention what it actually is. So place yourself at eye level when speaking with someone in a wheelchair. Tap a person who has a hearing disability on the shoulder to try to show that you are paying attention to the person and to get his or her attention as well. Look directly at the person and speak clearly, slowly, and expressively. Speak in a normal tone of voice. In the literature, many times we're trying, the authors, different authors are trying to tell us that we have to avoid the medical jargons. What I'm teaching all of my students is to be using the medical jargons, but to be expressing and defining those medical jargons in a very understandable way. This is a little bit of exceptional case. I would still recommend to be avoiding the medical jargons and to be using the normal, understandable language. Now here we come. This is the Universal Pain Assessment Tool. It was created and adapted, and basically it was created for the communication with people who are not able to express their pain and unable to express their individual needs. So, use of the Universal Pain Assessment Tool. I'm going to mention this from the perspective of dental, I would say dental direction, because I am the person who had been using this tool since 2014. You remember I did tell you about 2013 whenever I identified the patient who was in need, urgent need of endodontic treatment. The root canal treatment was extremely urgent. And then I started digging deeper. What tool can be used as an additional tool to be communicating with people with certain disabilities? And I came up with the Universal Pain Assessment Tool, and we kind of had been using this tool since 2014, and many research papers have been produced since then. Let me introduce to you some of the publications from the scientific field. So I'm going to try to talk based on the scientific evidence-based material as well. As far as we are scientists, and the scientists are also represented in the group during our session of today's evening. So I have listed some of the scientific research papers, including the papers which have been published in the high impact factor journals, the European ones mostly, and there is one of them which is also the Georgian Scientific Journal. So first of all, I'm going to be mentioning the special issue, the abstract, which was produced in 2000, and we produced this paper in 2014 while being in Glasgow in UK, and I did present the special with the help of Kent University Department and the help of Professor Marks. We did produce this paper over there, and the particular let's say poster was introduced to the community members over there. So afterwards we went for this research paper, which was the review, but this review did find itself its place at the American Psychiatric Association Publishing Group, and they cited the paragraph from this review. Also, the nutrition and oral medicine included the paragraph from this particular work. Then we had this, right? The ResearchGate, where we are having the scientists some of the feedback from all around the world. And I have been receiving, and I still am receiving every single Monday, the notices about the work that we're doing and that we are on the right way. And this is actually making me really happy, because I'm understanding that we are on the right way, that many of the community members, the researchers, professors, lecturers, students, just people who are interested about the field, they are getting involved. So two things are important whenever we're trying to involve the people into the conversation or into the topic and encourage people to ask questions. That's how we're raising the awareness. So as you see, almost 20,000 reads so far for one of the research papers, which was published in 2017. Actually, it was produced in 2016. Afterwards, it got the issue of 2017. And finally, there was 2019, whenever we did publish in the European Journal of Pediatric Dentistry the special paper as well about the use of the Universal Pain Assessment Tool for evaluation of the pain-associated aspects with TMD in youngsters. Now I'm going to try to give you some of the clinical and scientific information based on the characteristical matters that we have tried to identify. First of all, let me explain what TMJ is, right? So TMJ is the temporomandibular joint, which is actually having pretty much of the mobility. So it can be let's say having the lateral protrusion that can be seen markedly over here. In the right corner, depression and elevation, protrusion, right, the forward type of movement, and retrusion, the backwards movement of the mandible. So we are kind of like trying to mention TMD, right? And we know that TMD is the abbreviation of something, but what is that? So here we have temporomandibular disorder. That's the correct form of TMD, I would say, and for recognize this particular disorder. But it is also known as TMJ disease, TMJ syndrome, Costin syndrome, which was identified from the very start. Well, the National Institute of Dental and Craniofacial Research identifies the combination of TMJ and TMD, and they are calling it TMJD, so temporomandibular joint dysfunction. Well, the American Academy of Orofacial Pain, they're saying that temporomandibular disorders, TMDs, are most appropriate for the particular problematic issue. So this problem is embarrassing a number of clinical problems that involve temporomandibular joint, masticatory musculature, and associated structures. Now, the disorder transcends and boundaries between several healthcare disciplines. And it's pretty much multidisciplinary. And that's how me personally, I've been working on the particular research projects. I've been working together with dentists, together with oral and maxillofacial surgeons, OMFS, and neurologists, on the side rheumatologists, radiologists, and psychologists as well. Let me give you and provide a little bit of statistical information. So this problematic issue affects 5 to 12% of the population. Annual cost is estimated at $4 billion US. 1/2 to 2/3 of people with TMD will seek treatment. Approximately 15% actually develops chronic TMD, which means that 15% are not really treated at all, right? So if the chronic condition is going to develop, we understand that the quality of life drastically decreases. Second most prevalent musculoskeletal condition following the chronic back pain, which is mostly associated with lumbar spine, as we know, right? The lumbar spine is the problematic issue, which is pretty much associated and related to the back pain, resulting in pain and disability. One of the most common causes of orofacial pain after dental pain. Still, most of the dentists who are unaware of the problematic issue, they are kind of not really recognizing the particular medical condition, and they're missing the diagnosis. So I have to mention three, for me, most important things in medicine. This is etiology, diagnosis, and prognosis. This is the map of medicine. No matter which field of medicine we're going to try to touch, etiology, diagnosis, prognosis is the root. So we have etiology as the genesis of the problematic issue, the cause, which is actually bringing the diagnosis to the theme. Diagnosis is the correct identification of the problematic issue, medical condition. And of course, prognosis is dependent on diagnosis, but prognosis is also dependent on the etiologic factors, right? So etiology can be myofascial pain dysfunction syndrome. So for example, MPDS, which is having the correlation with pain at the TMJ due to the muscle tension. Spasms, right? So we have malocclusion, bruxism, which is also connected with daytime clenching. There are psychological factors, personality disorders, and stress and anxiety, increased pain sensitivity. You know what? Most of the doctors are thinking that this, so muscle tension and spasm, is actually the genesis of pain, so etiology. But I got to tell you that this is wrong. Why? Because they're actually not considering the etiologic factors. The etiologic factors can be these things. So muscle tension and spasms are actually caused by all of these listed over here. So we should not be treating this rather than these factors. So these are the main etiologic factors. Now, other diseases can be associated with it, such as rheumatoid arthritis, ankylosis, dislocation, infection, and neoplasia. So MPDS, and on the other hand, we have TMD of articular origin. So usually the differential diagnosis has to be set. Whenever we're touching the MPDS, this is unilateral or bilateral. So either one side, either both sides are involved. For the TMD of articular origin, usually it is on just one side, and this is unilateral. So rheumatoid arthritis is connected, but it is also related to the particular aspect of MPDS. In addition to functional limitations, pain associated with TMD can cause physical and mental distress in adults, which may lead to patients to take vacations or to be, let's say, unable to perform their normal activities, right? So it is pretty much reduction of the quality of life. So what is diagnosis? We touched the etiologic factor. Now diagnosis. William Osler. Sir William Osler did state something like this. Listen to your patient, he's telling you the diagnosis. And if you remember, in my above-mentioned slides, I did mention something about listening, attentive listening. So while you're listening, and I've heard there was the AADMD conference just recently, right, couple of few months ago, and I did have the opportunity to listen to some of the real patients talking about the real problematic issues, what they are facing. And they're always saying that, listen to us, doctors, physicians, listen to us, because we may be telling you something that is very important. They are lacking the, let's say, understanding from the doctor's side. We know that in the past old days, patients were just given approximately 18 seconds to be speaking about the medical condition, and that's it. So this was pretty much of the doctor-centered approach. We are right now living in the era of patient-centric, patient-centered approach. And indeed, the right treatment, after all, depends on the right diagnosis.
Georgi, may I add something to that?
Of course, yes, Dr. Eskide.
One of the things that you have to think about when you're working with anyone who doesn't communicate verbally is not just listening with your ears. So I tell people to listen with their eyes and watch the person. And there are so many times that I was asked to see someone who could not speak to me. And the first thing I would do was I'd pull up a chair and just sit and watch the person, watch how they moved, watch how they interacted, watch what they did. And you can learn so much by listening with your ears too. And that statement is very, very true. They will often tell you what is wrong. You just have to listen. So sorry to jump in, but I thought that was an important thing.
The very, very important notice. Yes, indeed, we have verbal communication, and on this side we have non-verbal communication as well, right? And something that I didn't mention was about the cues. The patient is dropping the cues and we have to pick them up. So if we're not going to be able to listen and maintain that listening and observational skills together in the synchronization, then we are at risk of misdiagnosis or missed diagnosis. Now, which is worse? I would say that both of them are very, very bad, extremely bad, right? So misdiagnosis leads to the treatment which is not applicable and which is not effective. Now, misdiagnosis is also leading to the direction of treatment which is not going to be effective at all as well. So this is going to lead to the sleepless nights, insomnia, and have negative influence on the quality of life at the end of the day. So what are the aspects of TMD diagnostics? Physical examination, so jaw malocclusion, abnormal dental wear, and poor dentition, visible clenching, spasm of the ipsilateral neck musculature as well, and restricted mouth opening. So palpation has to be done, right, below the zygomatic artery, and it should be 1 up to 2 centimeters anterior to the tragus, posteriorly through the external auditory canal. Now, the muscles that have to be palpated, this is the masseter muscle temporalis, lateral pterygoid, medial pterygoid, and sternocleidomastoid. So I have tried to illustrate over here the pain-related pattern and the sternocleidomastoid muscle, which is pretty much missed most of the times by my fellow colleagues. So what are the lab tests that can be done, lab studies? So in the suspicion of infection, complete blood count, CBC, can be done. Calcium or alkaline phosphate for a possible bone disease, for example, or serum levels of creatine phosphokinase are indicators of muscle disease as well. I have to mention also the imaging studies, because I did mention that the radiologists are involved in the scheme as well, right? So arthroscopy, magnetic resonance imaging such as MRI or CT, computed tomography, or dynamic high-resolution ultrasonography can be also be done. So differential diagnosis can be and should be also driven towards the particular pattern of medical condition. 1969, again, I'm touching the aspect of patient-centered, family-centered, individualized type of care. 1969, the term patient-centered approach medicine was introduced by Enid Ballant as understanding the patient as a unique human being. On the other hand, Sir William Osler did say that the good physician treats the disease, the great physician, on the other hand, treats the patient who has the disease. So the use of the universal pain assessment tool was characteristical in 2 directions. We had to determine whether the UPAT could be used as an additional and valuable tool and to be used as a valid instrument to collect data on functional TMJ pain to assess orofacial pain levels related to TMD in people with ID and SA1 youngsters. Now, let me describe SA1 youngsters for you. So the American Society of Anesthesiologists are giving us the classification as such. And in this sense, healthy patients are referred to as SA1, so SA1. So non-ID patients. Second issue of concern was identification of the TMD issue, which is originating from an early age, but we had to prove it. So therefore, we have differentiated the 2, let's say, groups of people. In different studies, we tried to identify TMD in people with ID, and we had 204 known Down syndrome intellectually disabled athletes. It was happening in Belgium during the European Games, and we did collect the data as such. So we tried to evaluate 5 jaw movements assessed over here. So whenever we're trying to open up the patient's mouth, this was happening: opening, maximum, and unassisted opening, and maximal assisted opening. So a little bit of a moderate digital pressure was used to increase the degree of opening if possible. For the lateral protrusion, so the side movements of the jaw, we were trying to ask to the patient to move the jaw towards the left and towards the right side. So this was happening 3 times, and we were trying to palpate at 3 locations. This was lateral pull, posterior attachment, and also the dorsal aspect. As for the SA1 youngsters, we had 291 patients, and the same type of assessment was being conducted over there. Now, muscles that were palpated, this was temporalis and masseter muscles. So we had, we used the SPSS software for the comparisons of categorized data to be collected and analyzed. It was a chi-square test and Fisher's exact test. The p-value was set at 0.05 and was considered, let's say, as statistically significant at this value. So the non-ID patients, which were 291 patients, we had a little bit of imbalanced female-male ratio, but it was like 172 male patients or athletes in that particular situation and 119 females. So males were 59% out of 291. We also made the standard deviation graph over here. So from 8 to 15 years, the mean age was calculated as well. And this is a little bit of statistical and information whenever it was analyzed. So TMJ was found in 15.4%. Great majority of it, 78%, was recorded as mild. As the severity of pain level increased, the distribution of pain decreased, as you can markedly see on the graph, on the figure over here as well. So non-Down syndrome ID athletes, 65% were considered to be male patients. Standard deviation also over here from that. This was the age distribution from 15 up to 23 years. And 32% were found to have TMJ pain. Great majority of it, 74%, was recorded as mild over here. And here, as well as the severity of pain level increased, the distribution of pain decreased, and this can be also markedly seen on the figure. Now, let's give a little bit of comparison. And you see that maximum assisted opening over here was pretty much distributed and was having the maximum amount of people who were having the experience of maximal assisted opening type of pain, and also maximum unassisted opening as well. First and the second places, right? So, but they did not really have the significant difference between assisted or unassisted opening over here, as far as p-value was set as 0.05. We see that the characteristic of maximal assisted opening was pretty much similar in both occasions, and they do share this characteristical component. So we also tested the sounds associated with pain, right? TMJ sounds, the click and crepitus type of sounds. And we can see that 65% in non-Down syndrome ID athletes did correspond to pain, and it was also synchronized with the TMJ sounds. 35%, on the other hand, did not have any TMJ sounds associated over there. But I want to mention right now that there were certain limitations. So unequal female-male ratio, which I have already mentioned, and only a particular group of people with ID were screened. So the pattern of Down syndrome was not taken into consideration at that particular stage. But it is very interesting if we are going to be doing the further studies inclusively towards the Down syndrome patients as well. Palpated only the TMJ, but not the superficial masticatory muscles in youngsters with ID, and palpation done with limited objective measurement of the force applied. So as a conclusion, I can say that the tool still was considered to have an effect, to be an additional tool to detect the existence of functional jaw pain possibly associated with TMD, and it can be considered to be the instrument to score pain intensity associated with TMD. At least it is going to be the initiative of understanding of the medical problem, so that the clinician, physician is not going to miss the diagnosis. So it is an initiative for future research in this field, at least, right? And here I would love to thank you so much, and I would like to give a very special thank to Professor Dr. Luke Marks and Professor Dr. Stephen Perlman, and thank you so much for listening and staying here with us. Let me get back to you right now. So, dear guests, dear students, dear professors, if you were having any questions towards me, I would be glad to be answering those questions.
Georgie, this is Alan. I think it was a terrific presentation. Thank you very, very much. Moving forward, I think in terms of education, you had mentioned hearing the voice of someone with IDD. We're starting to encourage people to have standardized patients, inviting patients with developmental disabilities to be our patient, to talk to our young clinicians, and to share with them the story. So I'm just encouraging people to interact as much as you can. The best teacher is the patient. So good job.
Absolutely. Thank you so much, Dr. Wang. Thank you so much. Yes, please.
Thank you, George, so much.
Thank you.
As a pediatrician, I wish this for young patients also to hear about this. The children, little about 12, 10, or 1, 2 years children, that mostly we observe them, yes, listening, but mostly observe how they playing, walking, and etc. Thank you for this brilliant presentation.
Thank you. Thank you so much. Absolutely. You have identified the specific characteristic. Observation, as Dr. Escuday has also emphasized the factor, observation together with the communication and listening. This is the triangle where we are trying to, let's say, balance, and this is absolutely giving us some opportunities and some confidence as well. And the patient is also pretty much confident in that occasion and is pretty open whenever they feel that you are involved in the decision making together. So try to involve the patients into the conversation. Try to involve them into the conversation from the standpoint that we have to explain and plan things together. This is most important.
Yeah.
And to add to that, you know, people with disabilities may not be able to verbally communicate with you, but they definitely communicate with you. People who don't have verbal skills communicate in different ways. We all communicate in different ways. When I do this, I'm communicating to you and I may not be speaking. And so this is just an expansion of that. And it may be a particular change in their level of activity, their level of interest in things, a facial grimace, or whatever it is. And we as clinicians, just like we have to grow all of our skills, we need to grow our skills in understanding this different way of communicating with people with intellectual and developmental disabilities, which spills over into children, which spills over into adults with various issues, including dementia, which we know is very prevalent. A lot of these same skills and actually a lot of these same conditions, like the Fatal Five we talked about, are much more prevalent in older people with dementia who have challenges in communication as well too. So the skills that you learn here as we talk about people with disabilities is very applicable to many people in different areas that you will see as a healthcare professional.
Absolutely. And the tool that I have introduced to you as well, the UPAT, the Universal Pain Assessment Tool, this is exactly where the problematic issue is. So if the person is not able to communicate verbally, then we are trying to ask to the patient to cross or tick or circle the right MOE, the facial grimace, that is actually quite suitable for the person's individual needs, I would say. And it was quite effective. We could say that, yeah, we have been observing the patients who were smiling, but actually ticking or crossing the smiley, which was crying over there. And then whenever we kind of try to dig deeper, we would identify the, let's say, urgent medical endodontic treatment could have been necessary in the particular situations. So indeed, absolutely. Now, Dr. Escuday has suggested again one more time the reminder towards the pilot course, and I have, let's say, managed to write down the email address, the official email address of GRUNY, Grigor Robakidze University, and I'm going to, let's say, one more time. Sure, Ms. Tamuna, please.
No, sorry. No, nothing. I don't have a question.
Okay. So info at gruny.edu.ge. This is the right email, the official email of the university. Well, you can send your emails, and we are quite limited, right, Dr. Escuday, in the number of participants over there. So
we are, but if we get a, we can expand it a little if we need to.
Okay.
I really want this to be a good pilot, and if you have colleagues that you think might be interested or might want to, that could benefit, please share them, share this information with them as well.
Right, share the information. So
and we plan to. So at the end of the course, there's a survey that you will answer, and we're going to look at those results and use those results to see if clinicians there thought it was an effective program, and whether or not this is something that could be expanded in Georgia and at the university.
Absolutely. I see that Kunal, maybe you're having a question over there.
Yes, sir. And so in that case, if one patient is not able to communicate with us, so what is the role of the family in that conditions? Like family members, what was the role of the family members in that conditions? To interact with them, or to get some information regarding the patient.
Well, as for the start, I'm going to mention something, and afterwards I'm going to give the chance to Dr. Escuday to respond as well. We know that there are, let's say, 3 types of audiences: primary audience, secondary audience, and tertiary audience. So our primary audience is considered to be the patient himself or herself. Now, the secondary audience are the people who are carers, the family members, the relatives, close friends. And once we're trying to identify that, okay, the patient is having the lack of capacity for the understanding of the issue, or whenever we are driving the informed consent pattern, that in that case, we're trying to use the knowledge and capacity of the secondary audience, and we're trying to drive them into action. Dr. Escuday, please.
I think you explained that very well. One of the things, though, that we often see in clinicians is that they go straight to the secondary audience, and they forget about talking with the patient themselves, just assuming that they won't have any understanding. And people with intellectual and developmental disabilities often have a lot more understanding than we give them credit for. And they also understand facial cues and actions and the ways that we interact with people. We can, as clinicians, can greatly affect the way a visit may go if we're, very using big movements and aggressive type activities, or if we're sitting very calmly, we can affect the way that the person with a disability might even feel comfortable in responding differently if they feel that the environment is comfortable. So while I will say definitely we often rely on that secondary audience, the caregivers or supporters, and the families in particular, who I will be very honest to say that many times the family members know way more about that person's disability than I know as a clinician. So I learn from them and I listen to them. We need to do that, but just don't forget about the person, the patient themselves, and make sure that we address the patient as well.
Right. Dr. Alan Wong.
Okay, thank you. You're very kind. I'm a professor here at the University of Pacific, and I teach a residency program, and we utilize a lot of the information as a telehealth kind of situation where we have the patient in front of us, and as well as their secondary support, talking to the patient in their most comfortable environment. So I think the environment is sometimes very important, that they want to be comfortable how they communicate. And sometimes we don't have time in our chair or in our office space to really make sure that they are comfortable. So the communication is very important. So Dr. Escuday's survey, his tool in terms of gathering information. What do you like? What do you not like? How do you express pain? All that can be done at home so that the time used when you're in the clinic is more useful, because a lot of times patients are like anything else. They're kind of afraid of the situation and the environment. So making sure the environment is kind of conducive for that conversation. The sound is toned down, the lights are toned down. A lot of that is helpful if they're in there, if they're comfortable.
Absolutely. I remember during the AADMD conference, there was one of the ID athletes who actually mentioned the environmental factors, and he did mention one of the characteristical issue about the beeping sounds that can be there at the clinics and hospitals, which they might find very irritating, and they don't really like that pattern as well. Absolutely. And Dr. Escuday also mentioned the health passport, which is including the characteristical issues as such. So information about the individual liking or disliking some of the things.
And just to be clear, there are many versions of the health passport. The one that I showed you is our version that we developed. I don't know how many versions there are that are translated into the Georgian language, but certainly, again, please use that and share it with others.
That Dr. Escuday, sadly, unfortunately, I got to tell you that we're lacking this type of document as such in Georgia. Even if it exists, like there are very scarce resources related to that, and it's having pretty much of the scarce usage, I would say, from clinicians, and many of my colleagues actually have not even heard about this type of document or this kind of passport that we have just mentioned today. So I'm seeing that Tamuna, would you want to mention a couple of words?
Yes, I just wanted to say thank you for this interesting webinar.
Thank you so much for being with us.
Thank you as well. And it was such a pleasure to be able to speak with everyone here and get to know you all. And I certainly hope to be able to meet you in person at some point.
Absolutely. I'm pretty sure that this is just an initiative step, our initiation of the collaboration, as Professor Mamuka Tafkalidze, the rector of the university, has also mentioned. We are looking forward to the future steps and future collaboration. And I'm hoping that this collaboration is not going to end over here. And I'm pretty sure that it's not going to end over here because of that enthusiasm and that vibration that I'm feeling in the room itself. So thanks to all of you for sharing your precious time with us, because time matters. I know about it. I'm wishing all of you great health and everything best. And basically, I'm not saying bye. I'm looking forward to the future collaborations and future meetings. And let's raise the awareness. Let's make this world a better place to live.
Okay. Thank you so much.
Thank you so much. Take care. Thank you, folks.
Thank you, everyone.
Bye.
Thank you so much.
Thank you. Bye.
Bye.